Hello everyone, I'm Rizwana Parveen, physiotherapist from PRS Neuroscience and Mechatronic Research Institute in Bangalore. Let's discuss about the topic of unnoticed complications in brain injury patients. Whenever we spoke about a brain injury, we always come up with the thought of a stroke, traumatic brain injuries, Parkinsonism, whatever thing might be. But today, especially, I'm going to give a detailed explanations about the unnoticed complications of the patient with a traumatic brain injury, that is, a post traumatic brain injury, and the post stroke complications that I'm going to discuss about. So, let's get into the presentation. Whenever we are in discussion about with the patient's clinical presentation, we usually know how the stroke patient's initial clinical presentations might be, and also know the traumatic brain injury patient's outline. But we may not notice something which is a later on complication, which means, especially to say, the patient might be present to you with some hemiparesis, a gait problem like difficulty in walking, difficulty in bowel and the bladder, that is bladder and bowel incontinence, difficulty in gripping and grasping and hand manipulations, difficulty in doing all the activities. So when it coming to the outline, the functional activities of the patient is get limited. The patient cannot able to turn by himself or come to sit by himself, or from the transition from sitting to standing, and from shifting from one chair to bed, or from the bed to chair, or from walking inside the room, or walking around the bed, or walking or reaching to the restrooms, or walking inside the house, all the mobility level will be affected in the patients. So overall, coming up with the outline, functionally, patient might be dependent for some period of time. We are giving certain exercise protocols for the patients. We are providing a adequate rehabilitation, but yet so we might be left some part. There always something a missing component in the realitic component. So these are the some of the missing component which we use to focus, which we forget to focus, and we which we will be dealing up with the later on complications. That is the hemi-neglect one, heterotrophic ossification, myositic ossificans, joint laxity lead to subluxation, some of the behavioral and cognitive changes in the patient, and post-traumatic stress disorder because of the functional dependency, neuroendocrine dysfunction, arthritic changes because of the weight bearing, cranial nerve injuries, Alzheimer disease, movement disorders, some of the tremor, ataxias, kind of things, and vestibular issues, that is the balance and proprioceptive dysfunctions and loss, visual issues. So these are some of the later on complication. So normally, as a physical therapist, whenever we are receiving the patient, we will start treating the therapy based on the primary presentation from the patient, which means the patient will show reduced muscle tone, muscle flaccidity will be there, muscle weakness will be there, joint subluxation will be there, patient cannot able to turn by himself, like completely truncal muscle weakness will be there. Deeper on, depending upon the site of lesion, patient might be having the speech difficulty, swallow difficulty, either facial palsy, Bell's palsy, or the patient might be having the incontinence, bowel and bladder incontinence, and the patient may not able to get up and sit by himself and cannot able to transfer from one place to another, which means he is totally dependent on that. So these are the exact outline. Moreover, all the therapists we will notice for, but there are some additional factors which will be influencing in the patient, that what we are left to notice. So those unnoticed things that we're going to discuss here. So joint subluxation is mainly because of patient might be having the scapular stabilizer weakness. The scapular stabilizer weakness mostly occurs in the hemiparesis patients. Initially, we will be doing some management like tone facilitation, we will be giving some electrical stimulation, tone facilitation. So even though some patient can be easily noticed with shoulder joint dislocation, but sometimes acromioclavicular joint dysfunction, acromioclavicular joint subluxation will be happen to the patient. It occurs because of complete scapular muscle weakness, so complete scapular muscle paralysis, which will let uh, which lets the patient's shoulder getting into downward pulling because of the gravity, and we may notice some of the sulcus sign also. So depending upon the weakness extent, we might be noticing some sulcus sign in the patient like 1 inch, 2 inch, and moreover. So the better we can give the brace from the very initial beginning phase onwards. Whenever you are start treating the patient, it is better to provide a shoulder immobilizer brace to the patient to prevent the further subluxation complication. Because whenever, even if you are focusing on the stimulator facilitation, joint setting with the proper positioning of the limb, yet still the joint has been in the hanging for the long period of time. So it is better to advise the patient to wear the brace to reduce the impact of the subluxation. Then next, when you are coming up with the patients with the cognitive behavioral changes, because of the patient is having some hemiparesis, paralytic kind of issues, because of their dependency towards the other people, receiving the external support, receiving the assistance from the patient, having some of the anomalous pain over the body, feeling some disturbances because of the dependency towards the bed bounded, patient might be having some of the cognitive changes. The cognitive changes is primarily occur because of the site of lesion. For example, large MCA stroke, MCA territory stroke, and ACA stroke mostly, and subcortical lesions. These patients might be having the cognitive ability disturbances. Additionally, when their personality, behavioral, and emotional disturbances might be happen because of the physical changes also. Yet the patient is also having some speech and swallow like oropharyngeal weakness. Their communication is not that much effective. So, if the patient is having any difficulty in learning, difficulty in observing, difficulty in recognizing, difficulty in localizing, difficulty in getting, grasping the new information and processing those information, definitely may lead to some psychological, like emotional disturbances in the patient, which means they know the thing has been particularly in front of them, they can able to recognize it, they can able to observe it, they can able to process it, but they couldn't able to store it for a long period of time, and they couldn't able to express it, which means sometimes the memory loss, the memory like short term memory disturbances also will be affected in the patient, which may lead to emotional disturbances. So all these things will lead the patient to being some anxiety, agitation, irritation, emotional disturbances, crying for no reasons, everything will be there. If the patient can able to read and write, they will express their thoughts through writing. But what will happen if the patient is having the weakness towards the dominant side? They couldn't able to express through any mode of communication. So they might be having some speech difficulty, either bronchosaphasia or either vernix aphasia. So or either some slurred speech. So depending upon the GC scale, if the patient is having V2, V3, it is very difficult for them to express, and also it is very difficult for the a therapist or from the attender to receive what the patient is telling. So trouble in understanding what others says and also what he says may also influence the emotional changes in the patient. So for these purpose, definitely the patient has to be gone under through with some cognitive therapy, like the psychologist, a medical cognitive behavioral therapist will definitely helping the patient to regulating their emotions, to controlling their thoughts, and to expressing the proper thoughts. With the help of speech therapy, definitely the patient can able to strengthen their vocal cord, strengthen their oropharyngeal muscles, and also followed by they can articulate the word effectively, and the fluent of speech will be getting up into the better. Along with the cognitive therapy, cognitive behavioral therapy session, patient can able to recollect their memory, can improve the memory, can able to learn the different things, can able to maintain the simple tasking to multitasking So definitely these patients might be having all these changes starting up from the physical changes over from the hemiparesis and from the behavioral changes and communicative issues and the emotional and personality management. With the help of a speech therapy, the patient can able to strengthen their vocal cords, and also followed by they can able to express their words with articulating the word properly. And also with the help of cognitive session, the patient can able to motivate themselves, the patient can able to memorize, the patient can able to learn, and also they can able to grasp the new information, and they can able to recollect the thing that what they have learned before. The mixing up and the informations and the details also will become very easier if the patient is having any cognitive session. So the post traumatic stress disorder is also managed by the cognitive therapist, whomever working with the patient from the very acute care setup. So sometimes if the patient is having any pseudobulbar palsy or from any subcortical lesion, definitely there might be some involuntary emotional expression disorder. So those things might be unnoticed initially, but later on stages when the patient is getting up interaction with their family members or getting up interaction with their peer groups or from the social interaction, definitely these emotional expression disorder will let the patient into a critical one. So those things can also be regulated by the cognitive behavioral therapist. Next, we are coming up into the neuroendocrine dysfunction. It is mainly occur because of the pituitary gland dysfunction. The patient might be having some of the like hormonal imbalance, either thyroid dysfunction, cortisol dysfunction. The patient might be like it is not immediately the patient will not get into this complication, but later on, like more than 5 years after the 10 years of the patient, like very acute stage. For example, if the patient is having young stroke at the age of 25 or from the 30, 36 at all, these patients as like definitely they might be having the risk of developing all these complications. If the patient can able to develop the stroke at the earlier age, for example, the traumatic brain injury at the very young childhood, definitely there might be some acromegaly, Addison disease, Cushing syndrome, some of the cardiovascular, autoimmunity regulations, thyroid dysfunctions, either hyperthyroidism, hypothyroidism, parathyroidism, and adrenalism, and some of the adrenal hyperplasia. Everything will be seen in those patients is mainly because of the pituitary gland lesion. It is not occurs immediately, but later on because of some of the degenerative changes occurs in the brain. These all changes, and because of some medication also influences, we all can get into it. So when we are coming up into the arthritis, the patient, whomever having the stroke, for example, the hemiparesis, and also from the traumatic brain injury, the patient, whomever is having unilateral weight shifting, which means they cannot shift their weight equally to the opposite side of the body. which they are usually depending upon the non-paratic side, definitely there might be a risk of developing the wear and tear stresses over the joints, and the patient will develop easily from the risk of osteoarthritis from the non-paratic limb. So the only thing is teaching the proper weight bearing activity, weight bearing exercises during the gait training and balance training is the only way so we can prevent the osteoarthritis in the post-stroke patients. In acute stroke patients, if the patient is not weight bearing up properly, for example, if you ask the patient to stand up, if the patient couldn't able to stand properly with a proper limb position, there might be some abnormal weight bearing stresses through the Q ankle, and followed by the patient might be having abnormal wear and tear stresses. Definitely, there might be a risk of osteoarthritis at that time for sure. So the quality of the evidence is very low, but the impact over the patient, which has been unnoticed by more over the therapist. Like we are receiving the patient in the acute care setup, we are treating the patients, and once the patient has reached their home, we don't have any communication between the patient and to us. Like more than after 5 years and 10 years of mobility from the patient with abnormal mobilization, definitely there might be a risk of OA prevalences. And some of the movement disorders mostly occurs the patient with cerebellar lesion, either from the traumatic one or from the cerebrovascular accident. If the patient is having any basal ganglion any basal ganglion bleed or over from the cerebellar lesion, definitely these patient might be having the developing the risk of hyperkinesia or hypokinesia, and also followed by developing the risk of truncal ataxia and tremor. So those things are the tremors additionally. So those things are not an immediate complication, but a later on complication. If the patient is having like TIA over the cerebellar PICA, posterior inferior cerebellar artery infarct, which is a TIA, transient ischemic attack, patient will experiences only some weakness and balance issues. But later on, after a week or after a month or after a year, definitely the patient can able to develop. So statistical studies has proven that definitely the patient can able to develop these risk of truncal ataxia or the tremor kind of thing of the very later on seniorhood ages is very a complicable one for the patient. Even if the patient can able to mobilize independently, if they are not functionally dependent towards the other, these movement post-stroke movement disorder definitely let the patient to be bed bounded again. So again they has to depend upon some people, so definitely there might be a risk of complication. The only thing of to prevent the movement disorder is to treat the patient properly from the very first ages, and also followed by teaching the proper exercise guideline protocol. So if you're receiving the patient with a traumatic brain injury or from the stroke, you have to analyze which part of the brain has been injured very prominently, either right side of the hemisphere or from the left side of the hemisphere. Either the patient is having like frontal lobe, parietal lobe, temporal lobe, occipital lobe, thalamus, basal ganglion, cerebellum, midbrain. You have to go through each and every segments, and you also have to go through which tract has been affected mainly, which part has been influenced mainly. So based on that, the signs and symptoms of the patient might be changed, the clinical presentation of the initial one, and also from the later on presentation is also get to changes. So it is very important to assess the patient from the very acute stage, or if you're receiving the patient for your clinic in the at the rehabilitation phase, like after a month, after 2 months, 3 months, 6 months, or after an year, it is very important to evaluate all the initial histories, and you have to set up a therapy protocol based upon the movement disorders. So now I'm going to discuss about a major four complication which we are not aware of the patient might be having this or not. The very first thing is the hemi-neglect, which means a unilateral neglect, hemispatial neglect, or spatial neglect. It is one of the common disabling condition which presents in the patient with a traumatic brain injury or from the patient with the stroke presenting with a clinical presentation of hemiparesis, which patients fails to aware one side of the paratic side, which means if the patient is having right-sided weakness, they are not aware of there is a right side for them, and also they are not aware of any person, any object, any scenarios which is happening occur towards the right side. So towards the weaker side, patient's concentration and the patient perception will be lost. Neglect is one of the most prominent and the long lasting one, because most of the patient with the neglect is happened mainly of the dominant brain. In case of non-dominant brain, there might be some sparing over the recognition, but there might be no sparing at all if the patient is having the dominant brain weakness, dominant brain lesion, and the dominant side heavy neglect. So, this deficit is mostly found in the patient with any hemiparesis. They are not unaware. They are not aware of. They are not aware of larger objects or even the people towards their neglected site, and their patient will not unaware of larger objects, even the people towards the neglected side, that is from the contralateral side, the side of the space which is opposite to the brain damage. So, for example, they might be eating from the one side of the plate, they might be writing from one side of the paper. If you ask the patient to shave by himself, if it is of male, they used to left the opposite side, which means the weaker side. They will be perfectly cleaning over the non-affected side. So the negligence from the ipsilateral of the brain, it is not differentiable. It is both common if the patient is having the ipsilateral and contralateral side. Sometimes the patient is also not aware of himself. So that condition will be called as anaxonosia. So they will not aware that they are having this deficit. So they might be as usually moving on from all the places, but this lead to some difficulty. So it is one of the picture from the patient who is having the neglect and with anaxonosia. So this is the normal view. They can able to view normally both the right side and the left side. But if the patient is having any neglect and anaxonosia, it is very difficult to note on from one side, which means they are not aware. From their perspective, there is no other side. There is only one side. So there are so many confusions with if the patient might be having any visual disturbances, or if the patient is not aware of. So, the neglect patient most probably will not have any visual impairment. They will not have any hemianopia. Mostly, they will be having the perception disorder, recognition disorder, and the observation capacity from the weaker side will be reduced. So, mostly, once you start treating the patient with appropriate therapy, we can overcome with it. So, based upon the gender, age, and the site of the lesion, there is no correlation. But from the site of relation, these are the side of the most prominent side for providing the gaze fixation, and also followed by providing the perception, regulating processing over the perceptions. Peristalvian of right hemisphere, superior temporal lobe, frontal lobe, superior longal physical, basal ganglion, thalamus, cingulate cortex. So these are some of the major prominent area which may go on for the site of lesion if the patient is having the traumatic brain injury, either a hemorrhagic one or from the stroke or from the ischemic one. If the site is gone for the lesion, definitely the patient might be having the processing issues. Definitely, the patient might be having some of the perceptual disorder towards the neglected side. So, the neglect will not occur because of any of the consciousness. Like, there is no correlation between the patient's consciousness and consciousness. It's totally depending upon the awareness of the patient. So, the patient will aware of their non paratic side. Patient will be aware of their non-paratic side completely, but they will not aware of their paratic side. That's the main key point here. So from the any movement or any sensory integrational activities, for example, if you show any objects from the patient to the side, definitely, there might be some processing. It's depend upon the extent towards the side. For example, from the temporal to medial, temporal side of the eyeball to the nasal part of the eyeball. There are two separations. Like depending upon the site of lesion, the patients might be having some of the recognition issues. Either the patient can observe the things which you place when you placed in front of them, like from the central part, when you're getting up into the side. Definitely, the patient might be having some of so these patients definitely might be having the difficulty in spatial visualization from the weaker side, getting attention towards the weaker side, getting perception from the weaker side, representing the object from the weaker side, localizing the exact thing from the nearer and the farer personal space from the weaker side, and complete recognition from the weaker side is very, very difficult for those patients. So when you're getting into assessments, these two things are most major. One, the cancellation test and line bisection test. The cancellation test is you can draw a cross-section line, ask the patient to cancel any one of the line in front of them. So you can able to notice patient will be more dominantly towards the non-paratic side. For example, you are scattering some of the number from both the right sides and the left sides equally, asking the patient to cross the number 1 or number 2 or any alphabetic word. They will be fully focused only on the non-paratic side. And if you inform the patient to look over the paratic side, then they will look upon it. Apart from that, there is no awareness of the patient. And line bisection test in terms, ask the patient to draw a long length of line and ask the patient to bisect the line in the center. If the patient is normal, you can see the spacing between the bisected line from the right and left will be equal. But if the patient is having any neglect, either the right side will be higher, left side will be very smaller, or either right side will be smaller or the left side will be smaller after the bisection. So you have to be very careful when you're providing these cancellations and line bisection test. You have to explain carefully and also you have to give the auditory cues in between. So some of the physical examination followed by some of the physical therapy like visual scanning, some of the visual therapy we can give from the right side to left side from up and down. Neck muscle vibration is also greater impact of getting the patient to conscious towards the weaker side. Transcranial magnetic stimulation, some of the optokinetic moving object stimulation, cold water vestibular stimulation, that is putting the cold water into the patient ears, moving the noticing the eyeball movement of the patient, and some of the galvanic current vestibular stimulation. Galvanic current will be placed behind the patient's ear from the weaker side. When you start giving the stimulation, the patient will be automatically looking towards this or getting the concentration towards it. And prism adaptation, wearing the prism glasses, asking the patient to draw the objects or draw the line pointing out. Limb activation, with the help of the visual cueing, asking the patient to reach out the objects in front of them or from the side of the neglected side. Mental imaginary training, sustained attention training, some of the attention training like frequently giving the auditory cues, eye patching, virtual reality, trunk rotation, transcutaneous, mirror therapy, and feedback. So all these techniques are the evidence based up to till date now. But from the practical perspective, a visual light therapy will be very much helpful for the patient from the starting from the non-neglected side, starting from the non-paratic side and getting toward the paratic side completely from right to left or left to right, from center to right, center to left, up and down in the horizontal circuits, in the vertical circuit, but the eyeball conjugate has to be equal for this therapy protocol. So I'll attach the evidence based all the criteria through the um, organizing committee so you can go through on it, but this will take long period of time if we started to explain. That's why I have given the very short outline. So this is the hemi-neglect. The patient awareness will not be there towards the neglected side. The only thing is continuous auditory cues, continuous auditory cues, continuous visual stimulation will be helpful for the patient to getting into it. The next one is heterotrophic ossification. So mostly in the neurological patient, it is one of the deliberating condition because the bone formation in the soft tissues is mainly abnormal. Because of the brain injuries or the spinal cord injuries, the patient might be immobilized for a long period of time. There is no risk of any subluxation or dislocations or any other fracture kind of thing, but yet the patient is developing this complication is mainly because of some of the nerve impingement and also abnormal bone formation and also some of the therapist side issues. If the therapist is giving any vigorous movement which may lead to some of the sprain and strain to the cartilages and ligaments, yet to continuously moving, there is no time for rest, wear and tear over the cartilages and muscles. So these also minimal, a short positioning of the limb, that is the crook lying positioning of the limb in the ICUs, and also followed by getting the patient not in a proper position, which means once you give the therapy, if you give the position in the crook lying position, like some hospitals you might be noticed, patient might be in the long sitting and all of the sudden a higher end of the bed and the lower end of the bed will be heightened, so as usually the patient might be developing some of the contracture, so the contractures will be later on producing some of the bony formation. So risk factors like the patient in the coma or in the mechanical ventilator or immobilized for long period of time, definitely there might be a risk of developing the serum alkaline phosphate, which and these serum alkaline phosphate might be having some of the indirect effect. So it is an idiopathic one. We don't know exactly what is the reason, but yet the patient is developing this complication. The patient, whomever is being immobilized for a long period of time, especially with the male patient with the brain injury, either traumatic brain injury or from the spinal cord injury or from the stroke, definitely they might be having developing this complication. There is an abnormality in the homeostatic balance between the calcium, oxygen, and the pH level because of the artificial ventilator. Definitely, the patient might be having the risk of developing the ectopic bone formation, which is abnormal and unusual. So, this may lead to additional bony growth formation, and there might be an and there might be the patient can't able to move the limb, so there might be alteration in the bone resorptions or new bone formation, either of the acceleration and deceleration forces. Sometimes the therapist will be giving the high speed of passive range of movement without knowing the significant illness over the patient, or from the any damage to the neuron, glial cells and vascular tissues might be triggering some of the complex cascades from the cellular level and molecular level over the bony areas. It is not a single day one, it is takes place over the month, over the week and over the month of time. Mostly the weight bearing joints like hip joint is the major joint and elbow joint is one of the most complicated areas. Hip joint and elbow joint is the major site of getting the HO. The patient with a secondary complication like what are the mechanism might be happen is some excitotoxicity, ionic imbalances, and mitochondrial dysfunction, oxidative stresses, neuroinflammations, and ischemic edema over the blood-brain barrier, which is crossed beyond the blood-brain barrier and the spinal cord brain barrier, blood spinal cord barrier. So there might be some changes and there might be some influencing over the abnormal passage of the molecules, which results in the osteogen and prostaglandin formation side issues. So mostly the patient with the hypothalamus and thalamic illness may also might be having the illness of developing this complication because of the osteoblastic proliferations. So, as I told you, because of the abnormal like neuroendocrine dysfunctions, parathyroid hormones and growth hormones is affected. So, the patient will the later on stage developing the complication of HO. So, this is the exact passage crossing the BBB or BSB permeability, release of osteogenic and inflammatory factors, which lead to OPS and differentiation. And there is some of the osteoblast and ectopic bony formations. So what will happen? The patient. So initially from the 3 weeks to the 12 weeks is the given article, but initially the patient with the prolonged bedridden for more than a 4 weeks, 5 weeks, or 12 weeks, definitely initially might be developing some of the musculoskeletal restrictions. The loss of joint mobility, loss of joint function is an subsequent factor, but initially there might be some swelling, erythema, heat, and pain dependency on the sensory deficit. Pain will be there and some of the hard palpable mass will be noted. Patient feels some pressurized over the joint. It is very difficult for the patient to move the joint also. Because of the stiffness and contraction, because of the spasticity, it is very difficult. We mostly conclude it as an edema or mostly conclude it as a rigid tone or spastic tone. Symptoms like the patient will be having the all this clinical sign, but when you examining the patient, you cannot able to move the joint up to the functional level. There might be joint restriction. If the patient is having any pain, definitely patient might be producing some of the painful symptoms, or the patient can't able to express the pain. Definitely they might be showing some of the signs. There might be warmth while inspecting, and pain will be there, tenderness will be there, joint swelling and effusion will be there once it is getting into deeper one. But but usually the skin problems, the hygienic issues is not influenced on that. The pressure sore, the pressure ulcers may also let the patient to get into these complications from one article suggestion. But seriously, while you are instructing, the patient might be having the reduced joint range of motion, and then followed by they can't able to move their limb properly. Once the patient is improving, while they are walking, they can able to feel restrictions by themselves. So this is one of the thing. And sometimes the patient may also go for the surgical excision also. So based upon the classification, we had a four classification. The very first stage is a bony formation. The second one is the bony formation will be bridging up between the two bones aside the joint. Like you can able to differentiate between aside the joint. You can go through with X-ray, which is more than 1 centimeter, and from the patient with the third grade 3, the joint space will be reduced to 1 centimeter, less than 1 centimeter, and the fourth one will be ankylosing formation completely. So here, the spaces between the joints and the two bone from the pelvic and to the neck and the head of the neck and the trochanters of the tubercles and trochanters of the femur is a major part here, because the space reduction might be lead to some ankylosing formations and the limb length discrepancy formations, and then followed by the patient can't able to move his or her limb properly. So early treatment is the gentle movement, gentle passive range of motion, and because of we have to prevent the ankylosing formation. But usually we usually found it in the more than 12 weeks, so it automatically patient might be having some of the restrictions and also followed by ankylosing formation. So surgical consultation will be happen because it is not a stopping one. It cannot be stopped because it been keep growing. It will be keep growing until to 9, more than 12 and 18 months for the patient to give some initial presentation. The patient with an orthopedic consultation definitely might be getting into surgeries once the patient is having their functional ADL activity leading with a moderate level of dependency. So medication like a non-steroidal anti-inflammatory drugs and the endomethacin, etherodrine, some of the bony formation arrest medication will be helpful, but yet the patient might be having some of the pain. So pain also will be given to the patient. Initially, when you're collecting the history, patient usually develop the symptoms of more than 2 months to 12 months. Like if the patient is bedridden, you can feel, but if the patient is not bedridden, you can able to feel the restrictions from the patient. You can able to feel the joint swelling, erythema formation, warmth and everything. From the physical examination, as I told you, restricted joint range of motion, pain and tenderness will be there. Erythema swelling will be found in the initial stage. Later on, there will be some calcification, there might be some hardening. So later on stage, patient might be risk of developing the DVT also. So we have to be very careful for the peripheral vascular diseases. And these are the some of the serum markers which we can identify in the patient with the HO. Alkaline phosphate will be elevated, which is not in the early stage, like more than a second week. Once the HO is started to appear, alkaline phosphate, ESR rate will be very much higher, osteoclasin will be very much higher, creatine kinase is also very much higher in the patient with the HO, but the creatine kinase is not specific one, but the once the laboratory investigation is detailed, we can able to identify. And the urine examination shows the elevated urine hypoprolin and the prostaglandin E2. So some of the hormonal factors like HLA B23, 22, HLA-A, or some of the factors will be influencing the abnormal bony growth formation is also detected in the blood investigation. So in the X-ray, you can able to see some of the popcorn-like appearance. You can able to see the fluffy appearance. So based upon the Bruker's classifications and Hassens and Graham's classifications, we have already seen depending upon the number of spaces between the two bones in the joint is a criteria to diagnose the serious and the specificity of the HO. And the triple bone phase in the ultrasound is a very rare one, which will not be taken in India currently. But once the patient is being diagnosed in the abroad, which those tests has been going on seriously. The next one is myocytic ossificant as occurs as a result of brain injury, but there is some clinical manifestation which is very much different from the HO and MO. HO mostly occurs in the bony side and MO will be occurs between the muscle. Once the patient is treated with the limb, for example, the patient is being positioning with a vigorous manner. Once the patient is treating with a passive movement or high vigorous stretching or for the cleaning purpose or turning the patient if the bedridden, if the patient is treated with a vigorous manner, we already know there might be some tear over the muscle, and these tear might be lead to some lactic acid leakages and also followed by some of the calcium leakages in between the muscle. But for these patients, so what will happen because of the neuroendocrine dysfunction? These calcium might be lead to abnormal formation of calcification processes, and also there might be a risk of bony growth formation. Calcification might be lead to ossificant processes will be found in this patient. As usual, CS serum alkaline phosphate will be high and the CPR will be high in this patient. It is not specific because it is mostly found in the muscle, but yet you are moving the muscle. If you stabilize the joint, if you ask the patient to do actively, the patient might be felt a severe pain. Pathophysiology is not yet diagnosed, it is not yet concluded clearly, but the local inflammatory activity in the skeletal muscle is very much clear here because of the endothelial mesenchymal activity with the skeletal muscle, and the osteoblastic formation will be resulting in the myocytic ossificant. Mostly 75 cases of is occur mainly because in the traumatic cases. But 25 case is occurs in the neurological patient. So this neurological patient, whomever is being coma, whomever is being immobilized, whomever is being partially mobilized with the therapy, and also not mobilized in the proper limb positioning may lead to the risk of having these inflammatory reactions. So there is no identification from the X-ray investigation, but the MRI investigation will be clearly show the calcification formation. The calcification formation in the CT scan is very much clear with the string sign. I'm really very sorry I couldn't get the photography, but I exactly damn sure once you going through with your patient, you can able to identify in between the muscle because there is no joint space, there is no space reduction in between the joints, in between the two bones in the joints when you're differentiating with the HO. In the HO, you can see those that popcorn sign, and but in the MO, you can see those string sign from over the muscle. So those mineralizations and classifications will be taken over through it, and EMG also sometimes will be helpful, but it is not that much effective enough. And when coming up into the management, the same like that, giving a gentle passive range of motion, gentle active range of motion, and also followed by the pain management is a very important thing here. Once the patient limb is ready, once the patient is coping up with the surgical management, then it is depending upon the patient side to excision the calcifications and the additional ossificant side. But it is very very risky one because once the ossificant bone or the calcified one is being disturbed, there might be some tumorous or cancerous formations also. So the patient has to be very much clear enough towards it. The last and the foremost thing is the shoulder hand syndrome, which is the post stroke complication, complex regional pain. You might be noticing some patient will be complaining about the unusual pain over the upper limb from the weaker side or the paratic side. They will not have any pain since they will be not having any sensory disturbances, but yet they will be having some jump kind of sensation. They will be having some pain, hyperalgesia. Once you start the flexing the fingers or extending the fingers, patient will develop very aggravated pain. Patient will be so restless and so aggravated. So these shoulder hand syndrome will be mostly occurs in the MCA stroke, thalamic stroke, especially we can see these conditions. And it is mainly because of the patient with the prolonged immobilization and the inappropriately drawing the IV injections into nearby the neurovascular sites, and the angiospasm and perceptual defect. Hemi neglect is also some of the reason also, and having some of the sympathetic dysfunction plays the major roles here. So we had a classification, we had a two classification. The first one will be occur is a direct impact from the nerve. The second classification occurs from the indirect impact of the nerve. So these are some of the trigger factors. So we had stages also. In the initial stages, patient might be having some of the joint stiffness, joint swelling, tenderness over the hand alone. They might be feeling some pain, sensitivity to touch, sensitivity to movement at all. Pain will be subside only if the patient is taking the rest. So when you're looking at the hand, it will be very different from the normal hand. It will be very edematous. The second one is dystrophic pace, which means the swelling hand will be started to wrinkle. The patient, it was completely dystrophic changes, like the muscle mass will be reduced, skin changes will be changes, and the bony will be very very prominent, but yet the patient will be still having the pain sensitivity and touch sensitivity. The third one is atrophic changes. The patient will be not having any dystrophic kind of thing. The muscle mass will be very much reduced, the pain tenderness will be reduced, but the hand will be like a clawing like of one, the stiffened one, it like an a bricky one. I will share the photography in the presentation so you can go through on it. The next one is science and based upon the site, there is no law, there is no range of motion, but some of the shoulder pain and the tenderness will be there while you mobilizing the limb. Elbow, usually patient will not show any symptoms, but in the wrist joint, when you extend the wrist joint, definitely patient might be having some tenderness. And hand and the digits, when you flexing the fingers of the interphalangeal joints and extending all those fingers, even along with the moderate edema, even if there is of no edema, definitely the patient might be crying in agony with a severe pain. And when coming up into physical therapy management, the only thing is mirror therapy, teaching the patient. Like as I told you, if the patient is having any heavy neglect, definitely there might be risk of developing um, these pain symptoms also because of the proprioceptive, because of the perception disorder, sorry, perception disorder. So with the help of mirror therapy, we can able to integrate the patient's limb for the active movements and continuous active and passive range of movement, and orthosis in the functional position is very helpful in reducing the pain. And acupuncture is, I'm not sure, but I have gone through the article, they have given that acupuncture sometimes might be trigger the pain, so it is not applicable in the rehab process until or unless the patient is coping up with the tenderness. Laser and the TENS is really very helpful in reducing the pain. So I have given the detailed informations about all the clinical condition, especially which we are not noticed. Sorry, I don't have much time to explain all these things clearly, but these are some of the complication which we are not noticing in our clinical setup. Please kindly make a note of it, make a special care towards it. Once you start treating these deficits, definitely you can improve the patient's well-being, because if you're receiving the patient is very much active but they are not aware of this side. That kind of patient will be coming, I am recovering from my stroke but nowadays I can't able to move myself, that is from the H1 demo. And then my lymph is too it is too sticky, I cannot feel the musculature in the hand. It is mainly because of the shoulder hand syndrome in the acute stage. So that's why detailed investigation is very, very important for the patient to analyze, so you can easily list out what happened to the patient exactly. Thank you. Thank you, Movement Master Academy, for giving me this wonderful opportunity for exploring such conditions to you. In case of any doubts, you can ask me so I can explain to the sir. I can explain you. I can reply you. Thank you.